A key area as well is also driving, and a lot of older people after a stroke want to return to driving to try and retain independence. So again, it might be around using cognitive assessment. So one of the batteries that can sometimes be used is the Rookwood driving battery. So sometimes we would do cognitive assessments that may highlight difficulties, for example, in executive functioning, visuospatial functioning, and then on the basis of that we would liaise with a patient's GP and maybe recommend that they are referred to a regional driving assessment centre, so that the cognitive assessments are really useful in terms of highlighting initial difficulties. I think cognitive assessments are also really useful in terms of, again, tracking improvement. So with dementia, we know that that's a progressive condition, so sometimes cognitive assessments will highlight areas of deterioration. With stroke and brain injury, we know that people can make, or that, you know, there can be improvements over several months and years. So sometimes cognitive assessments are really useful in terms of helping patients to see where they may have made improvements. So there are lots of different reasons for assessing cognitive functioning. And in terms of the assessments that we use, so we use various screens. Again, different services will use different cognitive screens. So we may use shorter ones initially, but later on in somebody's recovery after a stroke or brain injury, we have used parts of the Wechsler Memory Scale and the WACE. And again, the recommendations from that are really useful in terms of being able to support somebody to return back to activities that they previously did, or new activities that they want to take up, or again, kind of informing recommendations for employers, or thinking about people taking on voluntary roles in later life. That can be really, really important as well.